Okay, let me share my screen. Give me a minute.
Yes, yes, we can see your nice color in the screen. And we can see the television behind you as well.
This is just, I would like to just remind that I'm very happy to have so many friends. Now we are already more than 220 people in the meeting, and meaning that everybody wants to know what's going on and what is the way that we are working right now in aesthetic phlebology and all the ways in vascular surgery too. My previous presentation, the two ones was very nice, and I will just remind that I'm very happy because just after the COVID, I was trying to just get some kind of work, and I'm doing delivery. But right now, since Ayman give me some job, I'm able just to get something. I'm proud to have Ayman as a friend because I dropped my delivery shot, and right now I'm doing the lecture because everything stopped after the COVID. Okay, fine. The final idea of the CLACS is trying to improve the way that we are working and trying to just have a new wave of working that is trying to improve the way that the patient are coming after the laser and the sclerotherapy. And the CLACS are already was designed by Dr. Katsuo Miyake in Brazil, and he's mastering with very nice courses yearly all over the world. There are people already that they are developing the techniques right now all over the world. I will try to show the way that it's working. The acronyms of the first one, I just to remember, I don't have a conflict of interest. There is nobody else who just can interfere in whatever I'm saying. It's a new revolution in the vein treatment, and I think from my point of view will change everything that we are doing for so many years. Is the acronym of cryolaser and cryosclerotherapy, and together show us the new path for this kind of new treatment. The laser treatment is done under the frozen earth, which help the patient with the pain as well as improving the effect of the laser beam. Then the sclerotherapy with glycose 75 and no compression is applied. The whole treatment is done in one session, and the patients are very happy with it. How we choose and how we do the stuff? We do in that way. We use 50% glycose as a sclerotherapy agent, or 75. The ND-YAG laser 1064, a vein viewer, and a frozen machine. And that is something new that we have to remember as a vascular surgeon and as a phlebologist. And this is something that we have to change. To remember that we have technical requirements. The technical requirement for it is the phlebo suite. The phlebo suite has to be changed. The old phlebo suite is just an old one that we have to forget about it, and we have to invest in the machine. We have to invest in new treatments. We have to invest in trying to have the new tools for have a better results in our daily practice. Second one, you must have an augmented reality or a vein viewer. You must require a laser ND-YAG 1064 and a Fredo frozen machine, and also the sclero agent. Long time ago, you remember that picture? This is the picture that we have for so many years. The old phlebo suite with a tool from the physician who is doing the sclerotherapy, the skeleton that usually go 1 or 2 steps ahead, the light at the side, the improvised maybe tied by a wire of a new light. This is an old phlebo suite. That kind of old phlebo suite has to be forgiven. We have to get the new way of the treatment has to have like this. You will see the new phlebo suite has to have everything, and the investment of the phlebologist, the vascular surgeon, or the agency who will take care of your practice has to be like this. You see on one side, you will see over here the laser, you have very nice light, The floor is very good, clean, and well fitted for like a treating the patient without trouble. You might see also there is a machine of anesthesia. If you are in trouble when you do your treatment, you will be able to assist the patient. Also, you will have here the sonogram machine, meaning that the new Flevo switch is changing everything, and you must have this in your clinic to improve yourself and to have better results. What are the final idea when you have to do all the stuff? You must understand the venous disease. You must know anatomy. As I say, I'm a teaching professor of anatomy on my university. You must know about physiology, pathophysiology. You have to learn about your diagnostic tools. You have to have a very careful history and physical of your patient. And you must to learn and do the duplex ultrasound. Everything is also part of whatever you are doing to improve everything and have a different view and an aesthetic view of the treatment that the patient will require and will ask for us. The patient right now is not like the old ones that they just feel that whatever we are doing to them will fit for them without trouble. Now they are aware of the internet, they are aware of the treatment, they know everything, and they ask us for results and everything. The first part of that trouble is that photo documentation. Photo documentation is the key for our trouble. And when you have an aesthetic patient, you must explain him that the patient has to show everything, and you must take a lot of pictures. There are very nice machines. There is so many ways that you might able to just put that in a computer to have everything. In my office right here, I have four large TVs, more than 50 inches TV, to show the improvement to the patient after the first, after the second, and after the third session. Also, you must improve in the way that you put the numbers and in the way you are tapering the skin of the patient. This was one of the nurses who put over the skin of the patient a number, and then the patient get upset. If we was in trouble, the skin was not clear after we cleaned it up, and we were in trouble. You have to just realize that after the photo documentation, this is more than 80% of your task when you have those patients. You may see over here, there is a large collateral. There are veins that are draining over there. Over here, you can see 2 or 3 small spider veins. And in the right one, you will see when we put right side, we put a number, we put a series, and that kind of series, you will be able to have that kind of trouble, and you will be able to just fix the patient and try to improve everything. The other tool that you will require is the vein viewer. The vein viewer is a new machine who is just working and is giving us different view that we have from so many years ago. The vein viewer superimposes the data or the image directly onto real objects or environments. It connects the physical world to the digital world, making it easier for the people to learn information, make decisions, execute the task more quickly and efficiently. The vein viewer system will be able to work in and improve our practice, and the patient like it so much. To work by increasing the contrast of the veins by digital imaging a continuous spot over the skin using an infrared camera, enhancing the acquired image by a software, and then project the images in green over the same spot. This is the way that you, after the vein viewer, you will see everything. There is a patient, you don't see anything, and after the vein viewer, you see the feeder veins, you will see some small spider veins, and if you just increase a little bit higher, you will be able to see the capillaries, and you will be able to see the veins, you will be able to see small arteries shining over there, and giving to you the idea of what's going on already, and where is the area that the patient is in trouble, just to fix it with the CLACS. Now, the final slide for that first point is photo documentation is mandatory in CLACS and in all the phlebology aesthetic patients. This is one excellent point from my view. I just want to stop. I would like to have right now, from now on, the comments of the people. I have so many colleagues from all over the world who are doing the procedure, and I would like to know what are their recommendations and the way that they are working from now on. Omar, can you just
great. Thank you, Victor. Very nice talk, really. And as you said, we have a lot of phlebologists all over the world. We have Dr. Eugenie and Dr. Ashish from India, and we have those number of Brazilian fellows, Alvaro, Felipe, Luis. Let us start by Eugenie. Have a comment, Dr. Eugenie? Have a comment? Please, you can open your mic.
Yeah, thank you. My comments for the Victor. What is the diameter useful for this technique? Amazing. What do you think? What is the diameter of feeder vein or small vein we can use this technique on the patient?
Okay, usually my experience showed me that until 2 or 3 millimeters veins, I'm able to do it. But I've been working just a little bit larger with very good results with no trouble. But I would like to know what Dr. Ashish said regarding about that. What is their diameter and how did you start working with those patients, Dr. Ashish?
Okay, Dr. Ashish from India, please.
First of all, greetings from India to everyone. We started off very well on the talk. As far as the answer to the diameter thing is concerned, I think what is ideally recommended, the recently published white paper report, the CLACS technique in the phlebology, is 0.1 to 1.5 millimeter veins can be treated. Though personally, I do treat veins even up to 3 millimeters, and I have had no problem to date.
What do you think, Philippe?
I think the diameter is a good point of discussion. We've been using CLACS technique with very high rate of success in veins up to 4 millimeters. But the point is, we use a compression when you use in such veins. We've been using thigh-high class 2 stockings with a cotton roll eccentric compression. And it's been shown that it improves a lot of the results when you treat larger veins.
I have just a question for Eugene. Eugene, how do you work with the photo documentation and how you store it? This is some key of that trouble that we have, because I have in my office so many patients who just came, I take the pictures, and then after this, I do the treatment, and when they coming back, they say, I don't see the results. When you show the difference, everything changed and everything is clear. What do you think about Jim?
I need to say the first that I was certified at the Clinica Miyake from the inventor of this technique, from Kazuo Miyake, professor. And I finished this course at his clinics and all of the parts of this technique. And one of this is crucial for the documentation. It's a special camera, a special settings on this camera, special some kind of pose, and everything what need you do from one patient to another patient. You need to keep these photos in your some kind of archive. And when the patient do the procedure, he can't the possibility to remember his legs. And you, it's like a doctor, also have no possibility to remember every patient's what was the picture before and after procedure. And for documentation, it's crucial for this analysis and for these outcomes. You can search the patient's file and see what is before and what is after the procedure. And you can show for the patient, look at this. This is your legs. Yes, this is my legs. This is one legs we did the CLACS. Yes. What is the results? Nice, doctor. This is the crucial moment of the procedure. Thank you.
Okay, Dr. Hashish, I think you have an opinion.
Yes, I would just like to add to what Dr. Eugene just mentioned. Ideally, a DSLR, digital single lens reflex, should be used with an external flash, what Professor Miyake actually does. The external flash is rotated 180 degrees and it faces a white ceiling, and the DSLR is on an auto mode, so that without much expertise one can do that. I don't use an external flash, but I have settings in my Flebo suite where I have the same light arrangements for every patient. And as Dr. Eugene rightly said, it is a most crucial part of CLACS technique because there is no other objective evidence of improvement. And in fact, there has been a paper by, if I'm not mistaken, Santiago et al. In 2018 Phlebology regarding the patient satisfaction being improved, the perception being improved after they were showed the pre and post treatment photographs. So yes, photo documentation has to be very particular. In fact, it is said that we should have at least 20 pre-op and 20 post-op photographs.
Great.
Okay, there is just one comment. I have also the way that I've been using. I have two iPads, one on one side and the other at the other side, and I show the patient in two iPads the difference after and before, Besides that, I have a bigger camera also. Does any of you use that kind of exposure, or just you show you in your computer, or you have an extra TV where you show to the patient the photo documentation?
I basically show it on the, I have two 21-inch LEDs side by side, and I show it on them.
We have very nice question from Mark Whitley. He is with us. He said his question to Victor, can you use the duplex scan instead of vein viewer to assess the results? That's the question from Mark Whitley.
There is a new kind of proof with 10 to 12 megahertz of resolution. With that kind of special proof, you are able to see the feeder veins. That's why I show in the previous slide that duplex scan has to be done by the doctor who is doing the treatment. We must learn, we have to improve, and we must have the new kind of pro who just will help us with that kind of question that Mark asked us. We can do it, we can see it, and you can work without trouble. And this is a sclerotherapy or echosclerotherapy is another very nice talk that we will have in the future. Felipe?
Okay, there is another question from another question from Professor Rashad Bishara, one of the famous phlebologists in Egypt. He said, do you have experience using etoxysclerol or STD in CLACS?
Yeah, this is this part is just for photo documentation. I will show in a little bit further the next stuff, and we will clear that for Dr. Bishara. Okay, give my regards to him, and I will talk and I will show him what is the difference. Okay.
Okay.
Okay, I will go. There is some more comments from the panel.
Okay, let's keep it for the next
the next section.
Okay, let's keep going. Fine.
Yeah, keep going. Yeah.
Okay. Okay. When we are talking about how we do the treatment, the treatment has 4 steps. The first one, you must see the veins that we are seeing up from before. with augmented reality, with the visualization of the feeder veins. You might do it if you like it by the sonogram machine, but it's a little bit tricky because with the vein viewer it's easier, and you can do it by your nurse who will help you in the office. Then we do the application of the transdermal laser energy to the feeder veins and helping always in the overall with the telangiectasia that we see around. And the third is the injection of the sclerosing agent in the feeder veins. We usually use always to the cooler device, that is the Frido, who will put the temperature of the skin just a little bit down to have a better result and helping with the sclerotherapy and help us with the laser. I will show you, this is, I have from my panelists, I have some videos, and I would like to show you the way that we are working. This is from Dr. Galbao from Brazil. Something that you don't see, you're able to see after the vein viewer. Okay, this is another video from Dr. Galbao Alvaro. He's showing us how to inject, okay? Okay, this is the way that we see the feeder vein. You see, we are just looking at where is the hole and trying to find out where is the problem and trying to, after this, trying to fix it with the laser. Over here in the left picture, you will see a feeder with two small veins that are coming out over there. That one, we saw that the feeder vein is coming from up, from down. The other one, the last picture, is having the same. Okay, how we do the laser treatment? When we start doing the laser treatment, we cook the vein with the ND jack, and the ND jack T64 is give us a selective absorption of the light and the hemoglobin, hitting the blood inside and giving some damage to the basal wall. After we damage the basal wall, we put the vein wall, we expose the vein wall to the sclerosing agent, and after this, we do the sclerotherapy. How is the fluency, the spot, and the pulse width? This is the way that we are working. We use 6mm spot size with a fluency of 70 joules and a 15 millimeters. This is the Fredo machine, give it the frozen air, and over here you may see how we are giving just a small, tiny touch of the laser above the skin to try to reach the vein, and then just a little bit touch, not too much. We are not, I will repeat the vein, you see, we saw the vein over there, 2, 3, we repeat it again. It's not too much, you see. There is another one over there. There is another, okay. This is, I will show you more laser, okay. The same stuff, 6mm spot size, 60 joules, 15 pulse width. Look, we are trying to do the same. The Frido is working, frozen the skin. We saw the vein, and we are giving just a little bit touch of laser. 2 or 3 passages over the vein, just to cook the vein and to expose, to give some exposure of the intima, to after this give the last shot of the sclerotherapy agent. Then after we do that, we go to the next step, that is the cryosclerotherapy. And the cryosclerotherapy is the treatment of the varicose vein by the injection of one irritant that causes inflammation, irreversible damage of the basal wall. When we start, the original CLACS delivers 75% of glucose, but I also recommend glucose of 50, and I've been using STS and polydocanol in very small percent, and we have as a foam the same result that we have with the glucose. I will show you just in a few minutes videos of that stuff. This is when you finish with the laser, you just start doing the injection of the agent of the sclerotherapy. In my way that I've been working, is just give it just a teeny one, and you see how the vein disappear immediately after the treatment. I will show you it again. It's just a little bit difficult to just use the vein viewer and do the injection at the same time, because you must do, there is some kind of difference between the light and the way that you see. And you must follow just the image in the vein viewer to have a better exposure of your treatment. Let me show you. In the left one, we have STS or polydocanol at less amount, 0.2% after we treat it. Look, this is the injection. Just a little bit, not too much, because the people who inject the glucose give a large shot of glucose. I'm afraid of that. You see, and the results are very nice. This is the way that I do sclerotherapy, always in my office. I give just a little bit of time to know that I'm in the vein. When I see the blood coming through the point of the needle, at that point I give it the shot. And this is with the glucose 50 or 75. The glucose requires a large bore needle, 27 to above. You see, when you inject the glucose, is moving a little bit slower when you inject the foam. There are people who inject more than 10 cc in the same spot. I'm afraid of that. I just give, in the way that I've been using STS, glucose, of polydocanol, just a short amount of the agent, not too much. And then in these slides, you will see the fourth step of the CLACS. The first one, the visualization through the vein viewer. In the second one, working with the laser. In the third one, you will see small amount of collapsed vein. And then in the fourth one, you will see how we work with the last shot, giving the sclerotherapy. One more time, the injection, to show you how you're doing it and how is the way that I'm working. I usually use for that moment also the Fredo, but because of the situation of the movie, if I have, when I try to take and do the injection with the Fredo, I didn't have very good images, because the Fredo gives some frozen air, and the frozen air change the images for the view in the TV. Okay, this is some stuff that just bringing from my colleagues This is the before and after of Dr. Ashish Dadas from India. You might see one before the treatment and the other one after the treatment. You see how the vein, the feeder disappear, and also the branches are going down already. And at that one, you see the before and after too. There is another video of Dr. Ashish that will run right now. You can see over there the work in the same that me. He is doing cooking the vein with the laser. And after he cooked the vein with the laser, he inject at the same time. And you see the difference before and after, before and after, before and after. This is the way that we work, and this is done by Dr. Ashish Dadat from Mumbai. This is from Russia, Dr. Eugene Beresnoy, with the same stuff what we've seen from before. You see, you don't see anything, and after you might see where is the feeder vein that just came from above to below, and we have to fix that vein. Now, I will have the result. This is the way that Dr. Eugene works. He is cooking the vein. He has the Frido working over there. And after he finishing that, he inject with the he's covering. Set the Alma laser, the 1064 laser. He's working, cooking the vein. And after this, he gives the shot of glucose. He's covering the skin, and we will release the patient after this. Okay, at that point, we show almost everything. We show the tricks. We show how is the way that we are working. I would like to have the panel questions and comments.
Great, it was very nice and a very interesting presentation. Really enjoyed all these films.
I would like to welcome Mark Whitley to join our platform as a panelist. And we're very eager to join his meeting in April in UK. You can open your mic, Mark, and tell us what happened to your meeting and tell us your feedback.
Unfortunately, COVID happened, as we all know. I would say that was a fantastic talk, Victor. Really, really nice talk. And I've wanted to know more about CLACS for some time. I've seen small presentations before, but I've not seen such a clear presentation. Can I ask some questions?
Yes, sure. We are ready for the question. I would like to have also, besides of Mike, also, I would like to have the comments of the panelists from Brazil, because those are the guys who develop and we will start with that stuff.
Yes, Casey has already answered one of my questions online, which is lovely of him. And I'm fascinated by the understanding of this. When you're firing the laser, are you firing in just certain places, or are you running along the laser like a chain of pulses?
Can you repeat it again? I switched my earphone because it was too loud already.
Sorry, yes. So when you use the laser first in CLACS, do you fire in just certain points on the vein, or do you fire repeating along the vein?
Yeah, we're trying to shut when the feeder vein come out. This is the first spot that you usually trying to get, and then you are going around trying just to unveil and give some exposure of the intima of the vein to just cook the vein a little bit to have an increased amount of results after you do the sclerotherapy. This is the idea.
So you don't have to cook the whole vein, it's just certain areas, then the sclero.
You see the videos. I will set it up, and again, if you like to see it. You will like to see it? Is
Thank
the
you.
person ready to see the videos and again? I will go backwards. Because you see, I will go backwards and again, I will show you the way that I've been working, I will show you the way that Eugene is working, and the way that, you see, the feeder vein start over here at that corner. This is the first one that we shot. Then we are trying to find out where are the other veins that they are large, and we shoot over them. You see that point? Okay, I will show you the way that is working, is doing it Ashish in India.
So I think Mark is saying, do you do the laser every 3 millimeter or 4 millimeter? I think Mark wants to know the science behind your selection point for laser fiber. Is that right, Mark?
Absolutely.
Can I reply to it?
Yes, please.
Yeah. Hello, sir. So basically, your question is asking as to do we cover the entire length of this vein segment? So we are using a 6 millimeter spot here. So that basically means that the laser is covering 3 millimeter on either side of the point. So actually, so for instance, if the feeder vein is 15 millimeter in length, so usually we would like to give 5 shots. So because 3 millimeter on either side, and if the vein does not respond, then we can do a second pass. So that would be the answer to your question. So we do cover the entire segment, but then 3 millimeter on the either side because it is a 6 millimeter spot.
Thank you. And in that one you've just shown, Ashish, a very nice one on the front of the tibia, did you just use CLACS, the laser bit for the underlying feeder, and no laser on the surface? The surface is taken by the sclerotherapy?
No, sir. The laser is applied both to the feeder vein as well as the surface vein, the telangiectasias. It doesn't work that way. Because basically CLACS is all about synergy. The laser damaging the vein wall, causing the vein lumen to collapse, and the sclerosin getting trapped inside the collapsed vein segment. And that is how the synergy is produced. So whether it is the feeder vein or the telangiectasias, we need to use both.
You're not seeing any depigmentation of the skin from the laser?
Sir, we do get I do get some amount of bruising, which ecchymosis for a period of say 2-3 weeks, but it resolves on its own. But in my cases, I'm yet to find a pigmentation which has lasted for more than 2 or 3 months.
But you don't burn the skin. You don't get a white patch from the laser.
No, because we are protecting it with the cryocooler, the minus 30-degree air. That protects the skin.
And one final question, I know I'm hogging this, but I'm very interested. One final question is, did you use compression on that case you showed us?
No, if a patient is only is undergoing CLACS, no compression. At least I do not use any compression.
From my point of view, I think one of the biggest advantages, which I didn't realize till today, is the lack of compression. Because every one of my patients hates compression, and they all say to me, if you could stop using compression, I'll send all my friends to you. Compression is the thing that everyone hates after sclerotherapy, and of all the things I've seen about CLACS, that's probably the biggest message I've seen today.
Okay, Victor, I have some question. Thank you, Mark. Really, I enjoyed your comments and the questions. I have some questions from the attendees for Victor and the panel. One of them asking about, do you have one type of laser? You use Nd:YAG laser 1064? And another question, do you think using cooler, this is from Swat Dogansi, asking about the using of the cooler, does it induce a spasm of the venule and make it more difficult to cannulate? And another question from Wasila, Dr. Wasila from Egypt. She's a very famous phlebologist in Egypt. She's asking about the photo documentation, and also from different fellows from India and from Tiram, asking about it is not possible to make photo documentation in some countries. Can I get this quick answer for this quick questions? The type of laser and
Ayman, let me stop them. You know, that is not true. They have very nice cell phones, and if they take a picture with a cell phone, sometimes it's enough to just clear everything as a photo documentation. You don't need sometimes a special camera. You just need a very good light and just shot your phone over the area where the vein is already to show the patient the results. This is the idea. In aesthetic phlebology, we change the view, and the patients are very special. They will like to have the results. There are people who self-pay for everything, and they would like to see what they are doing for them. This is a new technique, and the people would like to see that they improve it as soon as you can. Eugene, what do you think? Can you answer the question that Dr. Ayman said?
Type of laser and the use of cooler.
Cooler, yeah. We use the cooler for the both reasons. The first one is during the laser, we decreases the pain of the skin. And the second reason, we protect the skin. And also the cool air enhance the effect of sclerotherapy. And we usually using the sclerotherapy in the vein which are not closed after the laser, just open segment of the vein, we need to use the sclerotherapy, not all of the feeder veins. After the laser, we have the collapsed. This is the sign of the photothermolysis. The most of the vein closed, and we need to put the sclerotherapy, the dextrose, only in the segment which are open still. This is the reason why we're using the cooling air. And concerning the sclerotherapy, and I like this comparison with the CLACS, with the when we're using the CLACS, we can use in the sclerosant. Never. The Kazuo Miyake said, he never done the sclerotherapy, and the invention of this technique, CLACS, its acronym, was invited him, not cryo-laser, cryosclerotherapy. You can do the cryo-laser, cryosclerotherapy with the STS or polydecanol, but it will be not the CLACS. CLACS never do the sclerotherapy. That's why you can't use the stockings that the Mark said. My patients hate the stockings. My patients too, because I'm living in the south part of Russia, and the people hate about the stockings. That's why I'm choose the CLACS without any sclerosant. You know, them more general effects after the sclerotherapy, it's a matting or hyperpigmentation. That's why we need to use the patient need to use the stockings. We're not using the stockings with the CLACS. This is all safety procedure. This is not needed the stockings. That's why we're not using the sclerosants, only dextrose and laser. And the second point about the cooling, I'm set. Thank you.
Alvaro, do you have some comments for us? Alvaro.
I have a comment, a very great comment from Kazuo Miyake. I want to read it because this is the very, very, very famous guy.
He is the one who make it. He is the one who we learn. Everybody learn from him.
Yes, exactly. And he has written, he had written a very nice comment. I read as it is Congratulations, Professor Canata and Ashish. Very nice experience and presentation. Perfect result. The most important part of CLACS is the synergy. When we perform sclerotherapy, the vein telangiectasia is already pre-cooked by the laser. Dextrose 50% is weaker than detergent and other detergents, but powerful enough to finish the job. Some extras, the high velocity avoid skin ulcers and dextrose come over.
Okay, Alvaro, do you have some comments for us? Open your mic, please. No te escuchamos, Álvaro. Ahora. No te escuchamos. Álvaro, you have to improve. Luis Fernando, this is another point that I would like just to clear and you recall you. There is some point of the quality of life. We ask the patient if they improve after the treatment, if they feel that the heaviness and the swollen and the complaint that he have in the leg are improving. And there is a very nice talk of Diane Albernaz and Dr. Albernaz regarding about that. Can you tell us, Luis, how is going on in that area with the quality of life and the way that we are working those patients in your area in the Albernaz clinic over there in Brazil? Luis.
Hello, everybody. Are you hearing? It's a pleasure to be here. Thanks for the invitation. Yes, last year in the pre-win in Italy, Diane has presented the oral presentation about CIP1, CLACS, and quality of life. And we had 49 patients evaluated, 96% feminine, and we compared before and after the quality of life Aberdeen score before and after CLACS. And the median before was 11.7 and after 5.8. So we had an improvement of quality of life measured by Aberdeen score in patients submitted to the CLACS therapy. And we found statistical significance, and we are prized with third place at Congress. And I guess it's a way to contribute with your brilliant presentation. And we are very proud to be here because we follow Razumiaki since the beginning, and we usually do CLACS as our main procedure in our clinic.
Okay,
Alvaro.
I have another comment.
Alvaro.
Dr. Ayman.
Okay, you have already, your mic already working?
Oh, please.
No, it's not working, fine. Okay, let's go through. Ayman, just follow through. And you want me to go through?
Yes, okay. There's a very great comment, and I have, I think many comments will follow this one. It's also from Kazo. He is telling us, I perform always recommend overlapping by laser shots by 1 to 2 millimeters and 2 to 3 passes in veins and telangiectasia. You run over the vein 2 or 3 times, as I can imagine, and you overlap by 1 and 2 millimeters from each spot.
Ashish,
Please.
Can you answer that?
No, this is comment by...
it's a comment.
Sorry.
Okay, fine.
Here.
But how are you doing it?
Yes.
Sorry, I'm sorry, sir. I was typing an answer. I'm sorry.
Yes, Kazu is saying He performed laser shots by overlapping 1 to 2 millimeter from each and run over the vein 2 to 3 times.
This is an answer for Mike Wiley, who asked us if you're going back and forth over the vein. He sometimes, Katsuo, sometimes is overlapping the shot and he's just cooking the vein when he's feeling that he didn't he required just a little bit more. You will see how improvement of the vein after your laser shots, and you will see with the vein viewer that a little bit of shrink of the vein after the treatment. Okay, might I go further? There is more comments, Ayman?
No.
Okay, I will go through.
Yeah, sure.
Okay, let me go finish the last part.
Sure.
Okay, the idea right now is just give it to you the pills for the young one, and I would like to know what is going on. The old phlebology room has to be changed for the phlebology suite. The phlebology suite has to have everything. The new wave in phlebology came because we have the laser, because we have the new machines, we have the sono in our office, and we are doing everything for the patient in the same place. You must have the laser setting and a spot of 6 millimeter with a fluence of 60 or 70 with a pulse width of 10 to 15 microseconds. The second one, always you have to remember that the cosmetic patient are different than the regular patient, and the patient require always the truth. If you are to repeat it, just repeat it again and trying to give and tailor in the way that the patient requires. This is your idea, and you will have a better results since you tell the patient how much the improvement that he has and how is you feel that the treatment is working. The third one, show the results as soon as you can. Now, usually, I have the first shot of pictures at the first time, and after the second time, when they came for the second treatment, I show whatever we have already. And the improvement is amazing. You will have an improvement more than 50% after the first treatment. After the second treatment, you will have an 80% and always more than 80 after the third treatment. Photo documentation, as we talked before, is the key. And you may see in the result over here, there is a large vein after the first shot and after the second shot, after the third shot, and we give in that moment, after the 3 passages of the laser, we give the sclerosing agent, and we have the very good result, and almost the vein disappear. The same one that you will have another one. There is a large vein that came with a feeder vein from below, coming the first passage, the second, the third, and after the fourth, you will see that almost the vein disappear. And these are the clinical results that you can see. You see the vein over here. Usually the patients are very special, and you see over here, you see the vein, over here you don't see anything. This is a much large veins after the improvement of the class, before and after. Then you will have a large veins. This is a very difficult patient because the skin is dark and you can burn with the laser. You have to be very careful when you have that kind of skin, because you can fail in that kind of patients. Then you see this is a large vein with a feeder vein. After 2 or 3 treatments, almost 80% disappear. You will have the other one over here. You see this is a large, small veins of telangiectasis with the feeder veins. Everything disappear after the treatment. What are the complications? Yeah, what are the complications? The complication as discomfort, bruising, pigmentation, and swelling. And the final comments are that the CLACS, the laser plus sclerotherapy, is a cost-effective therapy for spider veins in face and legs. Just to remember, this was the size of the fish before the laser in my office. And right now, it's like this after the laser. You must remember, this is the difference, okay? Before and after. you must remember that the investment that you do to have all the equipment, the laser, after 1 or 2 years is coming and make you a big difference. The system work in all the aesthetic patients and have to be mastered. We need to have, from now on, there is just 2 or 3 papers that just came from the Sehim Clinic and Dr. Miyake, who is mastering with a very nice course. We're supposed to have a meeting and we are working, trying to, if COVID led us to meet in May in Brazil with the 10 IMAP. It will be a very nice session, and I highly, to all the members of this committee, to go over there, meet Dr. Miyake. He's an excellent teacher, and he's teaching the system very well. And the system has to be mastered, and we have to have the very best workup. And for the final, I would like to show you something from one of our friends, saying something. Oh.
Do you listen to me now? No, yes.
Oh.
Now you listen.
Okay, this is the end. Thank you very much to everybody. The president of the state saying that he's the only one who knows the system. I think we must master our system. We have to, I have people from USA, India, Russia, Brazil, and all over the world. Thanks always to Dr. Kazuo Miyake. He is the master of this. We are trying to show part of our expertise. Now I would like to open the dialogue to all of our panelists to have the final impression and try to just join together in the way, trying to fix the way that we are telling and curing our patients. Thank you very much to everybody else, and muchas gracias a todos.
Okay, thank you very much. That was fantastic, and muchas gracias. And if we can ask all the panelists to give a few words as a nice closer to this session. Each panelist can open the mic himself and welcome Loyal Kabnik to join us from United States. So let us start by Dr. Ashish.
Thank you, Professor Victor. It was a wonderful presentation. It covered almost all the aspects in the time given. I would just like to, and I was wanting to do that for some time now, was a word about the use of STD or polydecanol in CLACS, and I would agree with Dr. Eugene. I personally would not prefer using any type of detergent sclerosant. 50% dextrose works well. After I had my training with Professor Miyake last year and I started, majority of the times the question is whether dextrose really works, and I can tell you that it does work. In fact, that was the reason why CLACS was pioneered by Professor Miyake, because the detergent sclerosants, they can cause ischemic ulcers due to the venous capillary reflux theory. There is a paper by Professor Hiroshi Miyake. So personally, I feel CLACS is definitely a promising technique. There are a lot of questions, whether the cost is validated, whether, how the 75% and 50% work, whether it is as good as sclerotherapy. Further studies are definitely needed, but it is definitely promising new technique on the horizon.
Okay, I'm Professor Mark Whitley. Closing remark.
Hi there, thank you. Just as a closing remark, I think that's one of the best lectures I've listened to for a very long time, and it's certainly one of the few that's going to change my practice, and I look forward to starting CLACS. And thank you all.
Okay, and Philip Mamprim, closing remark.
Yeah, thanks a lot for inviting in. And for those, mainly for those who are beginners, I think the spasm and the disappearance of the vein doesn't have to be a major concern, because if you cook the vein three or two times, the vein will disappear. If you wait about 20 minutes, the vein will disappear, and you don't have to be concerned about the prompt disappearance of the vein. The idea of cooking the vein is the way to go of the whole process. And when you cook the vein, you trap the sclerosant and you enhance your results. So don't be concerned about the full disappearance of the vein right away. Just to have some patience and the vein will disappear after all. Thank you, Victor. Congratulations, Prof.
Okay. And Professor Mahmoud Salah, closing remark.
Thank you very much, Victor, for this very nice illustrative talk. It's always nice to hear from you. I just have one question, one actually practical question, because I completely agree about the photo documentation and that you have to take some pictures for each patient, each visit. So, but after some time of practice, you will have thousands of pictures. How you archive them?
This is a very nice. I have 4 computers over here regarding my desk, you know, with too many pictures, you know, but I just keep looking down and putting up like an archive with everything, because the problem is like this. I've been practicing for more than 20 years, and the people come, we got the last shot, we show them, and you might see in my back over there a big screen TV, a 50-inch TV. In each room, there is one of them with a small computer with large capacity, with storage. We storage all of them. We put everything in folders, and we have we taking care of all those. Very nice. This is very good question, you know.
Okay.
Thank you very much.
Professor Loyal Kabnik, closing remark.
Yes, thank you very much for the opportunity. Victor, I've heard your talk before, so I really appreciate your knowledge base on CLACS. In the United States, CLACS is not very popular at this point. As you know, it takes a significant investment to have a laser, to also do sclerotherapy, but there's a couple of things that we would like to know. Number one, has there been a comparison trial between sclerotherapy and CLACS? Number two, there is a competing method with CLACS where they do sclerotherapy and then finish with laser. Why do you believe that laser should be done first before sclerotherapy?
Ashish, you will go, okay? You will answer?
Yes, you can answer, yes.
Yeah, sir, the answer to that question, why sclerotherapy would be first before, the laser would be first before the sclerotherapy is, the idea is to cook the vein and cause the vein lumen to collapse, and thereby helping the entrampment of the sclerosant in the vein and increasing the synergy between the two. So that is one reason. Secondly, and somewhat practically, if we take the puncture first, the blood starts oozing and then we have to put the cotton pellets. So once we do that, we cannot apply the laser. There's a second one. And the third reason would be, and again, it's a minor one, but still, after puncture, the laser tip is not sterile. So we do not usually touch the skin after the puncture. So those are the 3 reasons why we generally prefer doing laser before the sclerotherapy.
Okay.
Thank you.
And we'll take a final remark from Dr. Alvaro Galvao.
Yeah, okay, first of all, I appreciate the opportunity to participate in this meeting with excellent professionals, and we can discuss interesting subjects. Even in the times of coronavirus here in Brazil, let's not forget the science and the parts of our daily lives. And I want congratulations to explanation for you, Victor Canata.
Yeah.
And in relation to CLACS, we have to understand that technique that has been carried out in many places in the world and is very well accepted. Science combines 2 methods, laser physics and glucose chemistry. And many vasculars here are already being associated for chemistry with polycanal, with laser, with good results. We have had experience since 2012, and this process is proving to be excellent. And every day we add new methods, such analgesia with the fentanyl or nitrous oxide. What we look beyond the science is comfort is safety to the patients. The CLACS technique is a technique that brings added value and due to high investment we make. And the patients who pays for these services pays very well. And we have some investment is very expensive devices. And the patients, we want the comfort and very comforted to this work. In second place, very important to know the patient's disease to choose this treatment. The CLACS will work very well for telangiectasis and feeder veins up to 2 millimeters of diameters. Above this, it will able to close the veins, but we have to, if this is very large, we have some microcoagules. You show this flap suite is very important. This is necessary to complete the fab suite to a good work. Well, and finally, I appreciate the opportunity to participate and encourage this technique.
Okay, thank you very much. That is great. So we'll go to the final poll to take the opinion of our attendee. If we can put the poll up. The poll, the right percentage of cotton in garbage material to make thermoregulation and to have a good patient compliance. Is it A, not necessarily at all, and synthetic material product is sufficient? B, important and should be at least 50%, or C, natural cotton with 10 to 15% is the recommended percentage to avoid with condition and growing bacteria. If you can submit your question, and let me take the opportunity to thank all the panelists for their time, their contribution, and let me invite them to join us in this weekly platform. And let me invite everyone, because the month of Ramadan is going next week. So instead of Friday, our next meeting is Wednesday, which is 22nd of April. 3 fascinating venous and arterial lecture, and we'll announce on our Facebook page and Facebook group these lectures. If we can have the result before we finish the Congress today, if we can see the result of the poll.
Okay, Omar.
Yes.
Okay, as you see, natural cotton with 10 to 15% will be the recommended percentage to avoid a wet condition and growing bacteria. Before we go, I have just final comment. I would like to thank Sigvaris company, Sigvaris Group, because they are supporting this session and give us the opportunity to be here with you today. They made a very good job indeed for gathering us together. Also, I would like to thank the company of Prime Partner because their technology and sophisticated way to keep the project going. I would like to thank all eminent speakers that joined us today. I also thank all the panel, and it is a great opportunity to get all this panel. We have about 20 great caliber panel. I think it rarely happens to have 20 eminent professors in one panel with these great speakers. And I finally want to thank all the attendees. We have more than 220 following us during this meeting, and more than 20 others following us on the Facebook. Thank you, and see you on Wednesday. Please keep safe, and see you again on Wednesday.
Okay, bye-bye to everybody else. Thanks to
Stay
everybody.
safe.
Thanks
Be
to
healthy.
be safe. Okay, healthy. Thanks for everybody. Thanks. Bye-bye, guys. Let's leave.